more severe back pain. Indeed, we don't know if this is really true. I will answer you this question. Do we have really more severe back pain when do we have occiput posterior position? This is an answer. This is a question. Fatigue, discouragement, and a greater need for emotional support. Then, if you are a midwife or a doctor, we have to intensify the quality of support you are giving to this woman. And we have maternal and fetal complications like infections, hemorrhage, third and fourth degree perineal lacerations, postpartum infection, and even post-traumatic stress. Then this is a very important topic in obstetrics. We should know that we have some risk factors. To have risk factors, that means that the chance or the possibility of the occurrence of this event is higher. This is a very important study. It was published almost 20 years ago, but it's still valuable because there were many women and they showed the association between maternal characteristics and also labor characteristics and occiput posterior position. And the risk factors must commonly associated with persistent OP position at delivery, with higher rates of operative deliveries and obstetric complications, where epidural use, amniotic rupture of membranes, African American ethnicity, nulliparity, and birth weight higher than 4,000 grams. Then I will send you the presentation because these two figures here give an idea of the frequencies of each one of these kind of complications according to the risk factors. Then, for example, labor induction increased the risk or the chance of OP. Oxytocin augmentation, let me show you. Oxytocin augmentation, AROM. In this study, they showed that epidural anesthesia was related to a higher risk. It was significant, 13% compared to only 3.7%. And what's more, well, if the length of labor is increased, as long as it increase to the chance or the risk of OP position. Yes, these are the most important risk factors. But there are some doubts if epidural really increases the risk of malposition. Indeed, whether epidural anesthesia is a risk factor for OP position at birth is still controversial. We have, this is the Cochrane review, and it did showed any significant difference. We have only 4 articles or studies, randomized controlled trials that compared epidural anesthesia according to the chance of malposition in labor. And the result showed indeed appears to be more common in the epidural group, but the lower limit of the confidence interval just crosses the line of no effect. So this result is unclear. We have many studies, but not all, that observed that epidural anesthesia is more likely to be in place when a fetal position at birth is OP. Then, although we usually say that epidural increases the risk of malposition, there are some controversial yet in the literature. But this is a very important issue. About prevention and management before labor, yes, it should be good if we could prevent it, because as I've shown, we have many complications. Then if we could prevent this OP position, this should be a very good thing. And indeed, many people have tried or have experienced it. For example, this is I think it's a famous book. It was published many years ago, and they proposed or they tried to offer or to search for the optimal fetal position through changing maternal positions even before labor. This should be an antenatal prevention. And they proposed variations of leaning forward while standing or sitting upright, and hands and knees, and avoidance of deep squatting, sitting with legs crossed, semi-reclined, and supine. But indeed, we agree that, of course, this is a very important, because at least the woman will be more prepared for labor. But if this can change fetal position, this is not really sure. This is not really certain. A Cochrane review found only 3 trials, and they found that the use of hands and knees positions for 10 minutes twice daily to correct OP position in late pregnancy cannot be recommended as an intervention with this focus. Of course, to exercise is very important for labor, but we could not expect that this should change OP position. No, there is no evidence about that. Well, we have to diagnose it when women enter into labor. And we have to know how is clinical presentation and how to do diagnosis. Diagnosis of OP position is generally made by digital vaginal examination in the second stage of labor, only in the second stage of labor. I will show you that it's not useful to search for this kind of, or to make the diagnosis during the first stage of labor, because management will not change. And during the second stage of labor, if there is uncertainty with the clinical examination, ultrasound examination can accurately identify fetal head position. And there are many studies. Many people are studying the ultrasound to do this kind of diagnosis. But traditionally, we have been making this diagnosis using fetal heart tones, woman's abdominal contours, and Leopold's maneuvers. Sharma is an Indian doctor. I don't know if you know him. It's an Indian doctor, and him proposed some modified Leopold's pelvic maneuvers with the aiming to diagnose the OP position. Well, this is a picture. We can see this is a Leopold maneuver, but it's modified by Sharma's. Obstetrician stands on left side of patient and uses fingers, hands, and forehands of both hands in one maneuver only. Then it mixes the second and fourth maneuvers of Leopold's, and this is a Sharma's modified Leopold maneuver. It tries to make out the position of occiput in relation to the back of the fetus. I think this should be a good thing for a practical training, because we should have to put our hands in the abdomen of the woman. These techniques anyway, fall into the category of the art of midwifery. They are rarely studied. And anyway, Sharma's technique merits serious investigations. You should try to do it. You should try to practice it. This is a practical, this is a kind of practical training. The question is, anyway, can outcomes be improved by identifying and correcting fetal position before labor? Because these techniques are aims to diagnose it before labor. And there is, and even when we enter into labor, there are many doubts if occiput posterior fetal position can be detected with digital vaginal examination. Is this really right? No. Even when we have a very trained obstetrician, a very trained professional, there is a high rate of disagreement between ultrasound and digital examinations, higher during the first than the second stage of labor. And this is a very important because we are talking about very experienced people. And what they found is that even very experienced people cannot do the right diagnosis. Because of that, ultrasound has been studied, and it's a tool that should be used. Indeed, in our hospital, we don't use it frequently because it's not available. It's the equipment of ultrasound. It's not available inside the labor room, but it should be considered. If we can do it, and if we can train to do it, because it's very easy, it should be incorporated into labor room practice. No study found that digital examinations produced clinically useful or reliable information on fetal position in either the first or the second stage. Yes, some may be more skilled in low technology methods than others. And if it were demonstrated that this group of practitioners was proficient in determining fetal position, this skill might be taught more widely and effectively. Yes, there are many doubts. Of course, we have to train every time. We have to improve our skills because this is something that never ends. We began to train and to improve our skills very early in our professional life, and we continues it every time through our whole professional life. Back pain in labor is really a reliable sign of an occiput posterior position. Is this really true? Because I've always heard about that. I've always heard, and I've heard many people saying, if back pain in labor is more intense, this should be a sign of OP position. But only one study investigated the association between back pain and fetal position. And no difference was found in the incidence of reported back pain between women with OP position fetus. So don't assume the presence of an occiput posterior position of the fetus in the presence of back pain, nor don't rule out an OP position simply because the woman has no back pain, especially when labor progress is delayed. Then this association is not really true. Well, what about management? The optimal approach to correct malposition of the fetal head is there are still many controversies, and interventions used by healthcare providers in pregnancies with fetal malpositioning include maternal posturing, manual rotation, operative vaginal delivery, and even a C-section, if we cannot solve the problem. And management should be done according to the stage of labor. This paper is a very interesting paper. I should recommend it to you. It's an opinion. It was published 7 years ago, but it's a very good it's a very good paper. It's very didactic. We can read it easily. And according to the author of this paper, we should consider the management of OP as it may be encountered in contemporary practice according to the 4 scenarios. The first one, the woman is before the onset of labor. The second one, during active labor, but before full dilation. Early in the second stage, and finally, once delivery is indicated for arrest of descent or non-reassuring fetal status in the second stage. Well, if the woman is before, or if we diagnose an OP position before the onset of labor, the recommendations are for standard obstetric management. We don't have to change anything. First, majority of fetuses will rotate to an anterior position during labor, even late in labor. Then we don't have to do anything. Occiput posterior before labor predicts neither an increased risk of C-section nor the final position at the time of delivery. So there is no, it's even futile. It's not useful to diagnose an OP position before the onset of labor. It's very difficult to do it. It's not accurate, and it's really unuseful. And second, there are no interventions before labor that are effective in decreasing persistent OP. And this is the largest study that investigated these questions. More than 2,000 women were randomized to a hands and knees position with pelvic rocking from 37 weeks until delivery. And the rate of persistent OP position was the same. Well, again, I'm not saying that exercise is an unuseful or it's not should be done, because we have another kind of advantages for exercise during pregnancy. There are many other advantages. The woman will be more prepared for labor. But what I mean is that if our aim is to change fetal position, well, will not happen. If we diagnose OP position during the first stage of labor, well, now woman is already in labor. Yet, there is no evidence to support maternal position to encourage rotation of the occiput in the active phase. At most, such information might heighten vigilance regarding fetal position in the second stage. So we would avoid and recommend against any attempt to rotate the fetal head before full dilation of the cervix. Before full dilation, the failure rate of manual rotation is high, and at least one group has reported port prolapse, cervical lacerations, and non-reassuring fetal heart rate patterns with such an attempt. So we have to reinforce our support to the woman. We must be vigilant, but there is no kind of action here. And we have at least 2 very important systematic reviews about this topic. The first one is from Levy, 2021. They found 5 studies, and adopting a hands and knees posture does not increase the rate of occiput anterior position at time of delivery. Yes, we are talking about interventions made during the first stage of labor. And Cochrane review last year, they also found a very low certainty evidence indicating that the use of hands and knees posture or lateral postures in women in labor with a fetal malposition have little or no effect on the final fetal position. Again, I will always say that. Again, there are many other advantages. And because of that, we should use them. Spinning babes position, yes, these have been used all over the world. I don't know if you have been using it in India and the Middle East, but it's very important to know the experience of midwives and doulas because there is no evidence indeed about spinning babies. But we have seen and we have heard from doulas and midwives that this kind of positions of exercises during the first stage of labor and even during the second stage of labor, that this should be useful. Then we should heard them, and we at least they have no danger and no adverse event. Then they should be used too. And early in the second stage, then we are progressing. We were in the first stage of labor, and now we are in the early second stage of labor. If the fetal status is reassuring and labor is progressing, there is no immediate need to intervene because the spontaneous rotation to OA is yet very common. And if performed too early, any manual rotations or complications arising from them are likely to have been unnecessary. But the problem arises, and our doubts arises, as OP persists longer into the second stage of labor. First, because the probability of spontaneous rotation decreases and the likelihood of adverse outcomes associated with delivery from OP increases. And secondly, manual rotation is more likely to be successful if performed early than if it's attempted once an arrest of labor has occurred. Yes, and now we have a problem. And this is the importance of increasing our skills of care during labor. Because we need a balance here. We should not act immediately, but we should not wait too long. Then we need to have a balance. Our current practice, ours and that of the author of this paper, is to wait for some period of time, around 1 hour for nulliparous and 30 minutes for multiparous. Well, this should be individualized, possibly longer if we have an epidural, and then evaluate the patient for a prophylactic manual or digital rotation. But I will tell you something about prophylactic manual or digital rotation. About when we are talking about prophylactic digital rotation, we are talking to do it early in the second stage of labor. But I will tell you something about manual rotation early in the second stage of labor. We have to answer 5 questions. And these questions must be answered to guide the method of delivery for persistent OP position. First, is delivery indicated at this time? Secondly, is vaginal delivery contraindicated? Third, what is the true position of the fetal head? Fourth, should rotation be considered before vaginal delivery? And 5, if rotating, which method is preferred? Yes, I think this is the most important moment of our class today. The first one, is delivery indicated at this time? We know that ACOG in 2014 published a consensus about duration of second stage of labor. And they stated that before diagnosing arrest of labor in the second stage, if maternal and fetal conditions are good, we should allow at least 2 hours of pushing in multiparous woman and at least 3 hours of pushing in a nulliparous woman. And longer durations may be appropriate on individualized basis. That is what I was saying. We should individualize patients. For example, if we have a peridural analgesia, or if we have a fetal malposition, maybe we should wait longer, but we need that kind of balance. Well, if the fetal status is reassuring, maternal efforts are strong, and progress in descent is being made, an additional amount of time to allow spontaneous vaginal delivery of the OP may be perfectly appropriate. We can wait. But if arrest of descent has occurred in the OP position, despite adequate maternal efforts, it is likely that additional time without intervention will be successful in some form of operative intervention is indicated. Usually, the patient will have been pushing beyond the typical definitions of a prolonged second stage, and intervention is almost invariably warranted. Yes, we have to assess these patients in individualized basis, but we have to check if there is some progress. The second question, is vaginal delivery contraindicated? I have to say that this is the opinion of the author of the paper, and I agree with him some way. But there is no evidence about that. Is the fetus more than 4,500 grams? Yes. A C-section should be considered if we are sure about that. If no, is the biparietal diameter palpable abdominally? Yes, this is a signal of a very high station. We should consider a C-section. But no, are basic requirements for operative vaginal delivery met? If no, a C-section should be considered. But if yes, now we have to carefully examine the pelvis of the patient. And now we have to use all our skills. Now we have to assess the pelvis of the patient. Because if we have a suspected fetal macrosomium, high station, and a pelvis with marked android features, we should consider a C-section. We are here. We should consider. But how to assess pelvis? This is a kind of practical training. This is I think this is the core of obstetrical skills, to assess the pelvis, to assess if the baby is in a high position. In the third and fourth Leopold's maneuvers are very useful to assess whether the biparietal diameter can be palpated abdominally. Because if it is palpated very high, we should consider a C-section. Because even when we can see, even if the scope is visible on the perineum, if we can palpate biparietal diameter abdominally with this third and fourth maneuvers, no, this baby is in a very high position. It should be dangerous to do any kind of maneuver or intervention to proceed to labor. And how to assess or to verify or to identify an android pelvis? Yes, this is the very famous Caldwell-Molloy classification. We know that Caldwell-Molloy classified pelvis in 4 types, and android pelvis is typically a narrow and crowded anterior segment forcing the vertex posterior, combined with a forward sacrum and short posterior segment. And this, if we have an arrest of descent, an OP persistent position, probably our maneuvers or our interventions will not be successful, and a C-section should be considered. We have to check the true position of the fetal head. This is a very important, because as I have already said to you, even for very experienced people, there are a very high rate of disagreement when, or is a very high rate of wrong diagnosis of OP position. And if there is any doubt at all, we should use ultrasound to confirm the position of the occiput. Ultrasound detection of the fetal spine helps in determining the proper direction of rotation. Although unusual, the direction of the fetal occiput and the spine at the level of the thorax is not always concordant. Yes, it's like if the baby was looking at his own back like a turtle. I don't really understand how the baby can do it, but this can occur, and it's very important to know about it. If the occiput is aligned to the fetal spine, in order we can plan the direction of rotation in order to rotate to the easier side. We have to check if vaginal delivery is not contraindicated, but we have to check, should a rotation be considered? Because if we have an anthropoid pelvis, and the anthropoid pelvis, we have, indeed, we have a posterior segment. It's large too. Then it should be unuseful. Then in this setting, we would recommend an operative vaginal delivery from OP position without rotation, because it should not be good to rotate this pelvis or this baby. And the final question, should rotation to occiput anterior and operative vaginal delivery be performed? And here there is an algorithm that I find very interesting. Pay attention to it. Is delivery indicated because we have a very non-reassuring fetal heart rate? If yes, a C-section is better, because we don't know if our rotation will be successful. And if we have a non-reassuring fetal heart rate, and if it's really non-reassuring, we have to check it. We should lose time, and this is important. We cannot lose time in this kind of situation. But if delivery is indicated for other reasons, for descent arrest, and fetal heart rate is good, we have to check, because if pelvis suggests an ample anterior segment, like with a gynecoid pelvis, and assuming that the other requirements of operative vaginal delivery are met, no, we don't have to rotate this baby. But if yes, manual or digital rotation should be tried, because it's the easier and the more simple intervention. But if we don't succeed, now we have to progress for more invasive interventions like rotational forceps, even a C-section delivery, or vacuum delivery without rotation, or rotational vacuum. And the manual rotation is the other kind of interventions that should be trained, that should be part of a practical training, because uh, you can see videos. There are many videos in the internet. We can see, we can read the technique, but you will only learn if you practice. This is not possible to teach manual rotation only by non-practical trainings. But the technique is indeed very simple. It was already described in many books. And basically, we have to do a constant pressure with the tips of the fingers against the lambdoid suture to rotate fetal head into the OA position. Secondly, the whole hand is introduced in the birth canal. The head is then rotated after positioning the fingers and thumb under the lateral posterior parietal bone and the anterior parietal bone. As you can look in the figures here, in the point of view of the technique, it's indeed very simple. There is no mystery here, but it's you will only learn if you practice, if you train. And it's not, it have to I hope it was clear for you. It's not only about manual rotation. The whole situation must be clear for you. And there are many organizations like ACOG, they recommend to try a manual rotation for OP position. This is the 24 publication from ACOG, and they strongly recommend to try a manual rotations during labor. But there is a question, additional question, when to do it? And I'm sorry, but there is no answer, or there is no final answer until today. A Cochrane review, 2004, said that a prophylactic manual rotation was not useful. Currently, there was no evidence to determine the efficacy of prophylactic manual rotation early in the second stage of labor. But there was a study that was not yet published in 2014. But in 2021, they published it. And more presentation confirmed by ultrasound at the early stage of labor and with epidural analgesia. There were more than 200 women. And when they did an operative delivery, or when they tried the manual rotation, the intervention group had only 25% compared to 41% of OP position during delivery. Then it should be good. Then they recommend to do manual rotation early in the second stage of labor, early. Nonetheless, we have a new publishing 2022, and this is a review, a meta-analysis, and they found 6 articles and more than 1,000 randomized patients, all included studies comparing manual rotation of fetuses in OP position or occiput transverse position, all confirmed by ultrasound examinations after complete cervical dilation with either no rotation. Then they compared it. And the conclusions were that there was no difference in the rate of spontaneous vaginal delivery with early manual rotation, prophylactic manual rotation. Indeed, manual rotation of the occiput posterior position early during the second stage of labor was associated with a significant 12-minute decrease in the length of the second stage. And this was the only difference found by this review. So, which are the conclusions? Well, we don't really know when should be the best moment to do a manual digital rotation, if early or if later in the second stage of labor. Yes, there are yet some doubts. So we have to individualize patients. We have to check, and we need to know the whole picture of this patient. Its manual rotation should be, it's really useful, but we don't know the best time. And finally, this is the last resource, the Killen rotational forceps delivery. This is a kind of technique that is almost abandoned all over the world. Too many people yet do it. And because of that, there are very few trained people to do this kind of procedure. But a very recent review, it was published this year. Yes, this year, January. This is a systematic review and meta-analysis. They found 13 studies, and these studies tried to derive estimates of risks of maternal and neonatal complications following Killen rotational forceps delivery, compared with rotational ventouse delivery, non-rotational forceps delivery, or even a second stage C-section. And they concluded that a Killen rotational delivery is yet a safe management option in pregnancies with persistent OP position in the second stage of labor when compared with the other management options, even such a second stage C-section. Yes, this is a very important. We should talk about Killen rotational forceps delivery when every other interventions failed. Yes, this is our last resources. Because if every other interventions failed, we have we have only two options. The first one is a C-section. And we know that a C-section, when we have a fetal head very low engaged, this is a very problematic or a very risky procedure. And the rate of complications when we have a C-section in this moment is very high. So we should train. But the importance of training in rotational deliveries needs to be emphasized through regular simulation training, as well as through direct supervision by experienced operators. But this is the problem all over the world, because many hospitals or in many places, they don't do this kind of procedure anymore. Then if they don't do, there are no people that could teach the junior doctors or the more younger professionals. Yes, Lily, this is my last slide. Thank you again. I hope I was clear and you understood me. Thank you very much. I know this is a topic that it's not easy, and it's a topic that has yet many doubts even in the literature, but I think this is the topic that needs the more the professional have their skills in the highest level. We should have the highest level of skills in order to give the woman the best care they need.
Thank you so much, Doctor. Thank you for contributing your valuable knowledge as usual. And I guess we have, it was so fantastic. And if, dear friends, if you have any question, please write. We have a very special practice from Carol, one of our experts who is in this panel. And we want to hear from Carol. Carol, are you there? Can we hear your? Yeah, Carol has some special skill in chiropractor, and she is trained in Webster technique. Actually, she's with 45 years practicing home birth midwife from US. Right, Carol? Where are you? I guess, yeah. So
yes, I would like I would like to hear from the midwives and the doulas, because although the literature sometimes says that changing postures or spinning babies, even when they are not clear about the outcomes or the results of these interventions, we should hear from the experience of doulas and midwives, because they have their own experience that is, or that are very valuable.
yeah. Yeah, I'm waiting for Carol. I think she disconnected. So anyhow, we are waiting for her. And let's see the chat box. Asha is written, thank you for a great presentation. Very informative. Thank you, Asha. And please write your comments. You can turn on your camera. And Mahtavi Latha is written, as a childbirth educator, what should be the advice for mothers with OP babies when asked for a vagina or cesarean section birth? Yes, Mahtavi Latha. You can turn on camera, Madhavi, and ask your question. Yes, doctor.
Hello, Madhavi. Thank you for your question. Hello.
Hello. It was a great presentation. Yeah. So as a childbirth educator, I do a lot of these, whatever positions that you have showed, the prenatal yoga and all that. So we do follow those. And when it has been a persistent OP baby, so what should be the suggestion from our side? Like, should we tell them to straight away go for a C-section or try vaginal birth?
Madhavi, if the woman is not in labor, you should inform or to say her that the baby will change, will turn, will rotate yet. Then we should not be worried about OP position before the woman enters into labor. This is not a problem. We should not even search for this diagnosis. It's not important, because the baby is still moving. It's still moving, and it will move. And the most of them will be in all occiput anterior position when the woman is in the final stage of labor. So my suggestion is to tranquilize this woman and to say her, don't worry about that. This should not be a reason for asking for a C-section. No.
Okay. Thank you so much. I also have another question.
Sure. Where are you joining from, Madhavi? From which country?
India.
Very good. Lovely. Yes.
Yeah. So my other question is, if the baby is in the occiput anterior position at the start of labor, is there a chance that it can become a posterior and vice versa during the labor?
Yes, there is the chance, but because the baby will rotate. But when the baby enters into labor, usually it enters in a transverse position. Then it will rotate for an anterior or a posterior position. Yes, but it can rotate. It can rotate, and the final position will be determined in the final stages of labor. This is what happens in the final stage of in the end of the first stage of labor. But it can rotate, yes.
So so doctor, you mean to say that if even if the baby is engaged in the birth canal, there's a possibility of rotation?
When it is engaged, no. When it is engaged, it will even rotate. We should know there are some videos that should be showed to the woman about the process of labor. How are the movements of the fetal head through the birth canal? Because there are movements. It enters transversally, it rotates, yes, and finally it goes out. But it is always rotating. We need this rotation because the diameters of the pelvis, the diameter of the fetal head has to fit into the diameters of the maternal pelvis. Then it is always rotating. But sometimes it rotates to an OP position and it faces anteriorly. This is the problem.
Okay. Thank you so much. Thank you so much. I totally appreciate you answering. Thank you.
Thank you so much. I think Carol connected. Carol, can you please turn on your video and we can see your lovely face and you want to share your valuable information and knowledge and 45 experience with us. Thank you so much for your generous manner. Thank you, Carol. I hope you connected again.
Yeah, I connected. Can you hear me?
Yes, but I can't see.
I know, but I can't turn on my video, you guys. It's 6:30 in the morning here, and I just woke up to this.
Oh, thank you so much.
Yeah. Anyway, you don't want to see me right now.
Yeah, why not?
Anyway, I did not expect to do this, obviously, but I wanted to make some comments on the dear doctor and what he had to say about certain things. Because I'm a home birth midwife, I've been practicing for 45 years and just under 2,000 babies. I know that's not a lot, but I do home birth. And I live in a retirement community, but it's enough that I think that I can have something to say about this. I also teach shoulder dystocia. I do have a lot of data, but I don't think that's as important right now. But I wanted to make some comments about, I've been able to anecdotally, because there's no studies on this, unfortunately. I think there should be. I'm my heritage, I'm half Mexican, and I have I'm pretty skilled with rebozo. Do you guys know what that is, a rebozo?
Yes.
Okay, it's a Mexican shawl, and I've been able to rotate babies relatively easily most of the time with rebozo when I know that they're headed in a posterior presentation. Prenatally, we'll do it to coax the baby, and also in labor. And when we suspect we might be getting a posterior baby to prevent shoulder dystocia, I think sometimes babies can rotate from posterior to shoulder dystocia a little more easily. And so what we'll try to do is, try to get them to rotate prenatally as well as in labor. Also, we do manual rotation, but we'll do it in a way that's possibly different, depending on how engaged the baby is. We, as the baby descends into the pelvis, and we sense that the baby might be, wanting to head posterior, we'll get her in a knee chest position to help to rotate the baby. Are you understanding what I'm saying? And it, because of the pressure being off the cervix and a little more leverage, we get a little more leverage by putting the woman in that position. And also with using a rebozo, we'll get her in a knee chest position and wrap the rebozo around her bottom with us up by her head, doing a mantiata, which is shaking her pelvis with the rebozo, and we'll actually pull the baby out of the pelvis with a firm but gentle jerk, pulling the baby out of the pelvis slightly to be able to get the baby to reposition itself. And then often I do 98% of my births in water. So after I pull the baby out of that position, she pops in the water, and the water acts as buoyancy to help the baby move itself. See, we believe that babies can often and do often help their mothers, help them be born. And what I'm talking about is, I'm sure, relatively unusual to some people, but we talk to the babies a lot prenatally, and that communication helps them feel safe. And they also are, they want to please us, especially if the family has a good, solid foundation in their relationship. I know this sounds a little different, but I can tell you, I've seen it over and over again, how babies will respond, of course, to their parents' relationship, as well as their relationship with their midwife that communicates with them. And so this whole time we're talking to the baby and asking it that they need to move. And they'll often accommodate what we're asking them to do, or you can tell they're trying to accommodate what we're asking them to do by helping facilitate their position, whether it's digital rotation, whether it's external rotation. Because sometimes when we get the woman, when she has a baby that's heading toward being posterior, even in early labor or in late pregnancy, we'll do a rebozo on her hands and knees, and then either myself or my student or my assistant will be underneath the baby trying to coax the baby, and we listen by fetal heart tones with a Doppler as we're doing this. We'll try to coax the baby in more of an anterior position. We'll even tell her in early labor, if she gets in a knee chest position, she can just gently take her hand and push the baby's back gently to encourage the baby to move the right direction. Gently. If it doesn't move, obviously we tell her just go ahead and leave it alone. But at least you're telling the baby on some level the position, the rotation it needs to take, especially if the baby seems to be on the right ROT or ROA, because the studies have said that if a baby is in a right occiput position, they're more apt to rotate clockwise. I don't know if that study has changed, but this is what we had learned several years ago. Anyway, so I just had some things to say, and I wanted to just share what we do to help get the baby into a better position so it doesn't end up getting as stuck. And then we try to do a lot of prevention with regards to nutrition. We try to get them to, if they're prone to having big babies, or they've had a history of any stuck shoulders or whatever, we're cautious on who we take on, of course, but we'll often encourage them not to eat so many grains, to stay away from most sugars and chemicals. And because you need magnesium, a good source of magnesium and calcium in pregnancy to have an adequate uterine tone or for the contractions to be effective, we'll really encourage good nutrition, both on a holistic level, not only physically, but spiritually and emotionally. And, I'm pretty skilled at pelvimetry. So if I suspect a woman's having a larger baby, or, the baby's presenting questionably, I always send my clients to chiropractor care, and I find a doctor that is skilled in Webster technique. I don't know if you guys know what that is. He's got to be trained in it to be able to be skilled in it. And I've got a couple of doctors, chiropractic doctors over here where I live, that I send women to at the very least at the end of their pregnancy. And it's been very effective in getting those babies to present right in the pelvis. And I've got many, many, many stories. And like I said, unfortunately, a lot of this stuff hasn't been studied yet. And so we're hoping that that will change. Um, and like I said, I do pelvimetry. And obviously, if the woman has a history of any bizarre, needing like low forceps or vacuum or whatever, I will often check her pelvis to rule out things like, any pelvic abnormality or platyploid pelvis, android pelvis, some of the things that you spoke of, doctor. And like I have a tendency, and I've had 7 children. I'm 70 years old now, but when I had my 7 children, my babies had a tendency to go posterior. I have an anthropoid gynecoid pelvis. And so my babies would always start out posterior because my pelvis is deeper and a little bit, but wide enough because it was gynecoid. Because many times you've got, a combination of at least 2 pelvises. Most people are not, or many people are not gynecoid, classic gynecoid. So, mine was anthropoid gynecoid. And so I would rotate babies early in labor if I thought that they were posterior. And being a midwife, after my 3rd baby, I was a midwife. I would be wise to that. And so what happens is, because of that, I'm really try to be acutely aware of babies' positions internally. And shoulder dystocia, I've had some really significant ones, and mostly with babies that are larger. I think the biggest baby I did was 12 pounds, 4 ounces. And the woman was over 6 feet tall, and she was able to get the baby out. But it was, babies that are born with shoulder dystocia. Often, I always tell people, you've got to realize that many times they're born shocky, and they need to be rallied around, not with full on CPR usually, but with some kind of stimulation and maybe PPV for a time. But anyway, so I've had some really significant ones. I've had up to 8 minutes, not any more than that, fortunately. But babies that are coming through the birth canal already compromised, getting stuck is certainly significant. So I've never had to break a clavicle. I've never had a broken clavicle. And those kinds of things certainly can happen, but I try to be as gentle as possible and do everything I can preventatively. But we do things a little unusual, as far as not the classic, shoulder dystocia management, although we do use those techniques as well. But when you're trying to save a baby's life, you're willing to do whatever it takes, as long as it's safe, but it's best, like doctor said, to correct the baby's position before the descent, the full descent. And another thing we have found that's not the classic thought, but it's been proven in literature, is that you don't want to hurry or aid the crowning if you have signs of impending shoulder dystocia. Not to interfere with the normal rotation, I think, is another perspective. Whereas I think people get anxious when they see the turtle sign, when they see the baby, getting stuck at the brim, of the forehead. Those are all classic signs of potential shoulder dystocia, of course, and or probably probable shoulder dystocia, and that makes practitioners get nervous sometimes, and then they want to rush the delivery. But we have found, and I think the literature has proven, that if you allow complete rotation of the shoulders, you're less likely to have any problem with shoulder dystocia, especially if you know your woman. You have to do a lot of assessing. Your woman's got an adequate pelvis. She's got, plenty of room in there. And I don't do pelvimetry on everyone. I usually do them on babies that are breech, and twins, but I don't do them typically on everyone. But if I suspect I might be having an issue, I'm going to do that. Plus, you have to remember too that you've got ligaments and muscle and, all those joints in the pelvis that are mobile and very infused with relaxin, which is the hormone that really keeps everything soft and supple and movable. And you have to remember that even if you think the woman's pelvis is marginal, I don't ever go on that alone, ever. So I really feel that it's super important to remember that I believe God's built us in a unique way to be able to do this. And as long as there's nothing of concern, to proceed without any fear, because a fearful practitioner can cause many problems. And I think that is really important, to have that groundedness in your psyche. Anyway, I think that's all I had to say.
Thank you so much, Carol. It was so lovely and everybody enjoyed. And we have a comment from, from Asha. Asha, you can turn on your camera, my dear, because you had previous question. She says, very important aspect, Carol, nutrition is so important. Undernutrition is a big concern in rural India, where I've worked. So any and all abnormal presentation are sent from C-section. And we have one iPhone, I don't know the name, yes. I read her comment as well. iPhone, she's written, I am an OBG physiotherapist, worked with mothers during labor. I use spinning babies techniques during childbirth, and it has effect and help ease their labor and reduces. Oh yeah.
Yeah. Spinning babies, yeah. Gail. Gail Tully.
Yeah, Asha, you can turn on your camera and you talk, and even iPhone. I don't know if I can. Yeah, I can give you access if you want. Asha.
Yes, I have to go. I have another engagement, so that's why I have my camera off. But I just wanted to say it was so useful, and it would be great to continue to connect like this. Really practical advice, Dr. Edson and Carol. And I think just having these very practical oriented discussions really make there's so much nuance. And, one of the concerns I think now in India is because we have gone so heavily into interventions, to reduce maternal mortality over the last 20 years, that we really don't have skilled providers who are skilled in the nuances of attempting any type of any of these kind of maneuvers or anything like that, to be frank. Our C-section,
I've been wanting
now it's 70 to 80%.
Yes, I hear you. I've been wanting to go to India for years and teach. I'm going to be going to Israel, Turkey, and I don't know what with Turkey now, but Greece. And I've taught this in many different cultures. But the thing of it is too, is that I know it's hard to get good nutrition probably in different parts of India. And I think that that's another thing that, you know, getting to know what they're doing and whatnot can, because the sustainability of the baby in utero is huge, of course, you know. So if you end up with any kind of complication, the incidence of you ending up with a baby that's compromised, that is not fully nourished, you know, is huge as well. So yeah, I think that I'm happy to share my knowledge with you guys whenever it's necessary, whenever possible, because I've really, because I worked as an unlicensed, this is I'm not your typical, and I do work internationally teaching, but the thing of it is it's not the things that we do are not typical necessarily, and unfortunately, because there's not much in the way of studies. But at an anecdotal level, I think that you know, I don't think it's, if it's within reason and it makes sense to me, it does not, it shouldn't discount, you know, the potential.
We are helping to you. Don't worry, Asha and all of Indian colleagues. We are in India and providing this training in India. We have an upcoming conference and workshop in July with Dr. Edson and all of profession in India. Plus, this class is ongoing. Every month we have one class, and next month in March we will have obstetric in emergency obstetric with Dr. Edson. And plus, we are having many holistic midwifery training for India, 18-month course that is online and is for India as well. Don't worry, we are you. Yes. And I guess you are from South India, right, Asha?
Yes, that's right. I'm actually right now in Bangalore.
Yeah, Bangalore, very lovely place. Yeah, so keep in touch. We will have very fantastic online and offline course. You will use that, and it's all practical and clinical training. So don't worry, we are with you.
Great. Thank you all so much.
Welcome.
Bye.
Sure.
Yeah. Yes, thank you so much. Dr. Edson, you want to add something too? Because we want to wrap
Yes, I would like to thank Carol for your commentaries. Yes, they are very important, and I think this should be my final message. Although literature is sometimes faulty, and it don't give us the whole daily life, but we have to value all these maneuvers, spinning babies and rebozo. The experienced midwives is everywhere very positive about that. And we have to every midwife or every provider that cares for laboring women should know or should include this kind of maneuvers in their practices. This is the first one. Secondly, we have to train and to have good skills for assessing the maternal pelvis. This is very important. I found very interesting, the author of that paper said that these kinds, the classification of pelvis in the initial phases of his professional life, he was used to study these classifications only for theoretical purposes, for doing tests and examinations. And soon he perceived that this was indeed very important to assess maternal pelvis. We have to develop these skills, as long as the skills to assess the station of the head, because these are very simple maneuvers and are very traditional maneuvers, like Leopold maneuvers, to assess if the station of the head is too high or is engaged, because sometimes, mainly for junior practitioners, for young, for more youngest practitioners, sometimes there are confusion, and we can do wrong diagnosis, think that the baby is very engaged because we can see the head, but indeed is not engaged. Then we have to develop to improve these very important skills. I think these are my final messages: to value all these practices, all these maneuvers, exercises, spinning babies, and to develop our skills for diagnosis, for assessing pelvis, and for manual rotation. This is a very practical skill. It's very importantly. And rotational forceps, this should be our last resources, only when everything failed. And it's indeed a problem that occurs inside hospitals, and this is not a problem for home birth.
Yes.
Yes, I
may
thank
I
you
add
very
that?
much.
No. Yes, please.
Excuse.
Okay.
Do you mind if I say something to speak to
Sure.
what the doctor just said?
Sure, please.
Yeah, I just wanted to augment what he said. I agree, especially with regards to pelvimetry. I think that I remember in the day, because I've been doing this for almost 50 years, when all doctors knew pelvimetry and all midwives knew pelvimetry. And I think what happened is this, as the C-section rate became more, common, they said, well, if it doesn't fit, we could just always section the woman, And so unfortunately, I think part of the problem was that, but I think, and then another thing is to make sure that when pelvimetry is taught, that they include the very huge importance of the fact that the woman is infused with relaxin, the hormone that really gets the ligaments and the joints and the muscles able to be much more mobile. And so to not, just because you're feeling diagonal conjugate doesn't mean that the baby will not fit. You keep that in your mind, in the archives of your mind. But at the same time, you know that if she squats or if she does this or that, or you notice a little bit of tension on her right side, and maybe her what do you call it? I can't think of the bone that sticks out. What is it called? Anyway, it's not as flat. It's more convergent. Maybe, get her to lift that knee. What's that? Anyway, get her to lift that leg up, you know what I mean, to allow the baby descent. What I'm saying is using it to help us help facilitate the birth of the baby. And so if we look at it in a positive way and don't just assume that if it doesn't work, we'll just section her, because women's uteruses are precious to them. And, the more surgeries they have, the less likely they are to have more babies if that's their desire. So anyway, obviously, that's obvious to all. But anyway, I just wanted to agree that I think pelvimetry needs to be brought back into vogue with all practitioners, but not, not use that as the final source of whether a baby's going to fit or not fit in the pelvis. Even if she's platyploid, even if she's somewhat android, there all should always be a trial of labor, because I've felt women that were seemingly android, but their pelvis was adequate for the size of the baby that they made. And I find that at times, if you give women the right guidance nutritionally and whatnot, they'll make the size baby that their pelvis can adequately deliver. And I've seen it over and over again. So I And I'm not saying that they don't need some guidance, because some women will just complex carb out and they end up with huge babies with small pelvises, and good luck getting the baby out. So I think women need guidance in a positive way, but at the same time, don't discount the fact that the baby will fit often, even if her pelvis seems to be marginal. Does that make sense?
Thank you. Thank you so much, Carol. Doctor? So we have to wrap up the class. Thank you so much. I guess because we already crossed the time. So if you want to add something to wrap up the class, Doctor, or anybody wants to add something, we have many appreciation from all of the attendees. And thank you so much, Samira. Thank you, everybody. Faize Hashim Abadi, she's written, thank you so much, Doctor. It was so perfect and it was fantastic presentation, Dr. Edson. And some of the students, they had some language barrier and they joined us from different platforms. They are writing for me in different language. I'm trying to translate. Some from Saudi Arabia, they're writing in YouTube, and some writing in Instagram. They are from Afghanistan. They say thanks to you, Dr. Edson. They found it very lovely and fantastic. And they're requesting for some videos for fetal positioning changes that can be shown to mothers that Dr. Edson promised to share with us, and we will share with you through our platform. Yes, sure. And thank you so much. And thank you, Doctor. It was very helpful. Excellent session, very informative. Thanks a lot. And thank you. Yes. Thank you so much for all of your, our attendees from Australia, from, from UK and Iran. They're appreciating this session. They like to continue this session. Yes, of course, we will have next session on 30 March, 9 p.m. India Standard Time. It's about obstetric emergencies with Dr. Edson. And we have offline course. It's about 7 days course in India for July, and you will have all the informative session about holistic in midwifery and obstetric with Dr. Edson and entire LEC educational team. So if you have any more query, you can write and we will answer to you. Our email address is info@LilyMCenter. You can ask your question or any more query, please write that. Write your query in that email address. We will come back to you. Thank you so much, Dr. Edson. Carol, thank you so much. Love you so much. Thank you, Carol. Thank you so much, Amira.
Thank you.
And thank you, everybody from 15 parts of the world, 15 countries. Thank you again, attendees from USA, Britain, Oman, Dubai, South Africa, Australia, India, Austria, Jordan, Philippines, Nigeria, Saudi Arabia, and Afghanistan. Thank you so much. Love you. Keep in touch. See you 30 March in our offline class. Thank you. Thank you. Bye.
Thank you. Thank you. Bye-bye.